Oh, we are. Hello. Hello again. Yeah, thank you very much for coming, everybody. Welcome to all the guests and to members of the board. We've got quite a heavy agenda today, but with your help, I will try and keep to time and finish at 4 o'clock, but it wouldn't surprise me if we ran over a little bit. So enjoy a cup of tea, a tiny egg, and a grape if you need one. Health and well-being encapsulated in those two things. And with that, I'm going to go to apologies for absence. We've got apologies from Paul Bentley at the ICB, from Leanne Farrock, from Martin Riley of MCH, but Louise is here. Thank you very much for coming. From Matt Capper at Medway, Maritime, and from Dr. You're in attendance for us, so thank you very much. And yes, I was just coming to him, and Councillor Peake, who unfortunately is poorly today. He's just come back from holiday, not feeling very well. Now, one thing that we might need to do is think about a vice chair.
And that will be for the June meeting.
Okay, so we'll just sort of do that then. Yeah. So just to remind people, Jane Black has now left Medway Hospital. She was the vice chair of this, and we'll appoint a new vice chair at the June meeting. And I do intend, because it will mean a constitutional change, to make a member of the voluntary sector a permanent member of the board. So with the blessing of council. That's not unusual amongst health and wellbeing boards in the country. It's just never been done here, but I think it's the right thing to recognise the contribution that the voluntary sector make rather than just invite them to the board. So that'll come through a constitutional change at annual council. Hopefully it will find support, and then we'll have somebody as, if you like, as a permanent member of the board. Yes, Morty.
Thank you. I didn't mean to interrupt. I was just saying I'm here for the ICB. Yeah. Thank you.
Yes, Morty is here for Paul, which is helpful. Okay, I'm going to go to the record of the meeting. So my computer's behind me, so I just need to help it catch up. I think it's still on the Wi-Fi that I was on at the Ashford International Hotel this morning at the Mental Health Summit, which I was pleased to attend, and Scott Elliott was there along with other Medway Council Health and Social Care staff, so we'll in due course hear the outcome of that from the service changes that KMPT colleagues are hoping to make.
Chair, may I propose the record of the meeting, please?
Thank you very much, Mark. It's coming onto my screen now. So we're asking you, is the record of the meeting held on the 13th of February correct?
Agreed.
Okay. You've agreed that, Mark, as well. Thank you for working on everyone's behalf. That's very, very... just what we need. Thank you. There are no urgent matters today. As I said, we've got a heavy agenda. Are there any declarations of disclosable pecuniary interests and other significant interests, please? None of those. So we'll go to item 5. You'll remember that we have decided that we need to keep a really strong eye on our joint health and wellbeing strategy, and as such we've themed the meetings and are intending to look at elements of the health and wellbeing strategy at every meeting. So on this occasion we're looking at the healthier and longer lives for everyone, and I'm going to ask Ailish to introduce the next item, which is children and young people's mental health and emotional well-being, self-harm. Thank you, Ailish.
Thank you, Councillor Murray. So what the paper outlines is that whilst our rates for self-harm overall in Medway aren't necessarily higher, when we drill down into our young people, so our population of 10 to 24, we see that we are at higher rates than we are compared to Kent and also compared to England averages. There's been some work done looking at the data, and what you'll see in the paper is that there's a sudden spike in October 2022. We're still working with MFT to understand that spike a bit further. We believe it's because of a change in the coding system. So, for example, where a child previous to that might have presented having cut themselves, maybe that was recorded as a wound or as a laceration rather than self-harm. So we believe that it's down to a recording issue, but we're still working to make sure that that is verified. However, what I would say is that the data that we've seen since I wrote this report is that our rates of self-harm are coming down. So the last month, the latest month showed that we were below average, and the last 6 months is a decreasing trend as well. So that's more positive than perhaps the report shows, because we didn't have the data at that stage. I think what the report does show is a significant amount of work that's happened over the last 3 years to try and increase the level of low and moderate support that's available for our children and young people, so that they're able to access that support at an earlier stage and not wait to get into crisis before they're seeking support. There's a whole range of services that are talked about in the report that are available, and I won't go through them individually, but happy to answer questions around those. What the report also talks about is the self-harm group that was set up as a result of the identification of this increasing risk group of children and young people. It's a partnership piece of work with Medway Health Watch, with the Medway and Swale Health and Care Partnership, and with Medway Council. And there's 3 sorts of areas that group has been looking at. The data work that I spoke about earlier. They've also been looking at mapping the resources and support that's available and ensuring that's well communicated to parents and professionals and young people. And they've also been doing some direct engagement with both children and young people as well as professionals to understand what some of the barriers to access might be and why they may not be accessing the support that is available. So as the report identifies, that work isn't complete yet, but we do have some early findings from those reports that are included in the paper. And some of it is that people don't fully understand the scope of services that are available, and also that young people have this belief that you need to be in crisis before you access support and are not coming forward for that support earlier, or believe that the services are only for crisis rather than for early intervention and support. And finally, the report talks about where we're going with next steps, and some members of the board may be already aware that we are commissioning a therapeutic alliance for Medway. So we're commissioning this separately. Kent are commissioning their own therapeutic alliance. And what we're doing through this therapeutic alliance is trying to pull together that amalgamation of services that I have talked about into a single pathway and a single service, which will make it much easier for both professionals, children, and their parents to be able to navigate the pathways, but still keep that low and moderate support available, so we're not escalating into needing CAM services or crisis services before children get to that point.
Thank you very much, Ailish. That's a really helpful summary. And before I come to questions, look, this is a critical issue, isn't it, for our young people, and has a lasting effect on their lives, because the evidence of the time when they were going through this period stays with them. And I think that is always both shocking and difficult for everybody to handle when those young people in different parts of their life encounter this. I was particularly concerned, Ailish, about the Section 3 and the prevalence among different groups, I think. And as ever with the Health and Wellbeing Board, we're here to look at this report and to think about the ways that we can effectively around the table make a difference to this. And it's, I think, therefore very helpful to have you here, Celia, to have Kelly here, so that we think about all the different places that we encounter young people and how we can tackle this problem. So I'm going to open it up to questions, asking you to be mindful of the fact that the interventions that we can make keep this group of people out of hospital and can prevent future escalation of the reasons why they decide to put themselves in this position. And I think for so many practitioners, and particularly those who work in education, you know, this is a very challenging condition to encounter, and one that it can be very difficult to start the conversation, but starting that conversation is crucial to determining the direction that that young person will take, whoever picks it up first. So the support that we can give to parents, and the support we can give to practitioners in education, and indeed for our looked after children and other children in social services, is really crucial. And it's a kind of, well, one of those issues, I think, that has got quite a high profile, but isn't talked about very much. And that's a strange dichotomy, isn't it? But I think it's one that kind of encapsulates the way that society receives this. So I'll open up for questions now. Andrew, please.
Thank you, Chair. I agree with everything you've just said, actually. But other than, actually, I think amongst young people, and I reflect on my own children, that actually in friendship groups, they do talk about this. But I suppose there is the connection about how a friend can help another friend without betraying a confidence as well. So I think there are some challenges in that area. I think from my own personal experience, you do see more young people with clear, who have been self-harming. It's much more prevalent than it probably has, you know, and that's a real concern. I had just a couple of questions. I thought it was an interesting report. I'm wondering, and I've been involved in a few EHCP cases recently, actually, and one of the big issues has been access to services. So where a child is identified with a mental health issue is how quickly they get access to service. And I'm wondering, I couldn't see much in this report about improving the speed of access. There are some children that I've been dealing with recently who've been waiting for a referral to NELFT, and they've been through the whole EHCP process, and then all of a sudden they get their EHCP and then they get oh, come see us, we can deal with your appointment. I'm also wondering, for some children, I was noting that neurodiverse children, children with other learning needs are in this group who do self-harm, is we're not identifying those additional needs fast enough. And that is actually one of the triggers for self-harming. And if we were better equipped to diagnose children, get them through the EHCP process faster, that we'd have more success in reducing. Ailish, I was touched by the fact that only in the last 6 months we've seen an improvement. I thought I understood the graphs, albeit there are some indications in some of the graphs, I think. But what has been the impact of the strategy? You know, we've been running it for 3 years. It's only in the last 6 months we've seen a drop. So what is going on? And are we confident that this strategy works for the remaining period? And finally, something that I'm becoming more determined is to see young people not accessing social media. And I think this is one thing the government should be considering, is taking action so that young people do not access social media until they're at least 16, because I think it is toxic and it is at the root cause of a lot of issues amongst young people. There are children as young as 9 and 10 that I come across who've got access to WhatsApp and they're bullied mercilessly on it. And there's nothing schools can do, because ultimately that's a decision for parents. I do think this needs some government action. Thank you, Chair.
Okay, so 3 elements there. The sort of impact of the work that's been done, the relationship between ECHPs, and whether or not there's a relationship between self-harm and social media, which I think there is. I would just point out to you, Andrew, the report does deal with the difficulties of navigating the services that people have had. And I think, in part, by working on that, that's why we're seeing a late change, because it has taken a while, actually, to make sure that people understand the way to navigate the service. And I have to say to people this morning, you know, having had a whole morning listening to a huge amount of lived experience, people with mental health problems generally, navigating services, understanding the way that the NHS and partners configure mental health services, I think continues to be a problem and a barrier to access. You're right about that. Anyway, who'd like to respond to Councillor Lawrence first? Ailish and then Celia, please.
Yeah.
Okay, thank you.
Okay, thank you. So I guess in terms of accessing services and the comments about referrals to NELF, I suppose it's important to distinguish between, sorry, I thought somebody was asking me a question. It's important to distinguish between whether they're being referred to NELF for neurodevelopment diagnosis or whether it's for mental health. because when and I'll wrap the impact question into this a little bit as well, because when we look at the impact of what we've been doing, so what we've been talking about is delivering services across the I Thrive framework, and that's about meeting children's needs at different points. So as their needs escalate, they will need different interventions at those times. And what we've been trying to do over the last few years is populate those earlier areas of the I Thrive framework to ensure that those early intervention, early support services are available. Because what we were learning from social care and from schools and from others is that children were not meeting the criteria for CAMS, so then their needs were escalating whilst they were in other services because the needs weren't being addressed anywhere else. So I would say it hasn't been a 3-year strategy around self-harm, it's been a 3-year strategy around looking at the breadth of the service that is available to meet children and young people's emotional well-being needs and mental health. And what we have seen is a significant decline in our waiting times for access to mental health services through CAMS. A lot of the work we've done is also looking at who the children are that are on the waiting list for CAMS and what sort of support they're looking to access. And that's why we've commissioned our services like our short intervention therapy service, which is specifically for care experienced children, very trauma-informed, trauma-based counselling and support through that. But also most recently commissioned our low mood and anxiety service, because it was recognizing that a lot of the children who were on the waiting list for CAM were on the waiting list for group work around that anxiety, exam pressure, relationship stress, those sorts of things, and being able to support them at an earlier point and take them off that waiting list for CAMS by being able to meet their needs. In terms of the EHCP, I'm not going to go into too much detail because I'm sure Celia will pick it up, but I think the really important thing about an EHCP is that what we should be doing through an EHCP is addressing a child's identified needs. We shouldn't be waiting for a diagnosis to have an EHCP to be able to support their needs. We should be putting the support in even whilst they're waiting for that diagnosis. And I think that that's where we need to get the process right in terms of identifying a child's needs rather than trying to think about whether we can identify a child's diagnosis or what they need in terms of that. So the impact of the strategy, I think, can be seen not just in the reduction that we're seeing now in the self-harm data, and you're right, it does kind of ebb and flow, and you will have those sort of seasonal changes. But what we're seeing, as I said, for the last 6 months is now a 6-month downward trend, which we haven't seen before. We've seen it go down, but it's gone straight back up again. So now we're feeling more confident that that is a downward trend, and we are going back to the previous levels. In terms of accessing social media, there's an awful lot of information and evidence around that at the moment. I mean, obviously, it's for us collectively to influence the national policy around that. I think it'll be really interesting to see what comes out of the changes that Australia, for example, are making, and see what learning we can get from some of those other areas and how that's been embedded. I think the challenge will always be if you put in a policy like that and either parents don't believe in it so they don't enforce it, or children find a way around it. And I think that's why it'd be really important to learn from some of those areas who have introduced it, so we can address some of those loopholes before we put the legislation in around that. Celia, I don't know if there's anything else.
Thank you, Ailish. I've got Celia, then I've got, just to let people know, Mark, Simon, Malty and Tracy, and then I'll come back to you, Andrew, if you want to respond to the answers that you've had and make that the speakers for this item, because I'm conscious that we want to try and keep to time. Thank you, Celia.
Thank you. So there's lots of things, aren't there, that affect or would have an impact on those outcomes. I mean, obviously, we have made significant improvements in the timeliness of EHCPs. A request that comes in now is being met within 20 weeks, and we've put additional resources into schools to support children whilst they're waiting, and also rolled out trauma-informed practice and supporting schools in that. What I would say about children with SEN, though, we under Section 19 have a duty to provide education for children who can't attend school for a health need. The majority of children we get referrals for are for mental health needs, and the majority of those children are actually highly academic. They're from grammar schools, they're girls, that meet that criteria. They're not necessarily the children with SEND. Actually, particularly this cohort, is a different cohort altogether. And I know that some schools, certainly, the not talking about it is an interesting one, because there's a fine balance between talking about something and making it a bit of a culture and copying behaviour and dealing with the underlying issue. So it's a really delicate one, but it's not all SEND, this cohort. This cohort actually is some of our very academic girls and young women. Yeah.
Thank you very much, Chair. I had a question on prevention and drilling down perhaps a little bit more in how we join up the various services, and then a question about evaluation very quickly after that. I was pleased with, for example, paragraph 5.3 of the report, the Medway Therapeutic Alliance trying to provide young people with one front door to services. And I also noted paragraph 4.7 about the self-harm project. I just wondered, how joined up are we in identifying the causes of young people getting into these situations? I know that some work has been done on loneliness, and it's not so long ago since we had COVID, and there might still be some knock-on effects, I suppose, in terms of young people forming relationships, interrelationships with other young people. And I just wondered if we looked at things in the round as to what leads to self-harm in the first place, if that can be captured in a reasonably succinct answer at this meeting. The other thing I wanted to comment on was what the officer said about the group that's dealing with the statistics, and in the report there is a reference in Appendix 1 to looking at the statistics. I wondered how far this had got, particularly, to give one example, in terms of evaluation. Paragraph 4.6 talks about the Medway Youth Service and the work that youth workers do at the Medway Maritime Hospital. This is laudable, and it's a service which has been in place for some time. I wondered at what stage we would be evaluating how successful this was, and other authorities that were a bit ahead of us in introducing this. I believe it's been in Glasgow hospitals for some time as well that youth workers have been involved. But my real point is that, are we learning from other local authorities that might be a bit further down the road as to what experiences they've had with youth workers in terms of results and getting round to preventing the sorts of things that this report is setting out to try and prevent. Thank you.
Thank you, Mark. So an important question there, please, on the veracity of the youth service in being able to make a difference with this, because I think as with so many of these issues, and particularly mental health issues, making every contact and encounter count is really critical. And I do remind the whole of the board, because Mark, part of your question alludes to that, there is an extensive appendices, and there is a lot of information there as well that can be shared on networks of the board for those around the table, and that is readily available to schools, and a whole lot of links at the end to sort of take that further. So on that question, to what extent are we involving the youth service
If I can
in places
start,
like hospitals?
Yeah, if I can start, I might pass over to Kelly to pick up some more of the specifics around it. So in terms of that being joined up, again, it's been a real focus of our work over, I would say, probably the last 5 years, actually, is about, because, and you might question how well it's working there, because what we do here is, we didn't know about that. Oh, that's a great service, I didn't know about that. And so there's an awful lot of work that we've done as a team and as a partnership to try and improve the awareness and understanding of what is available, and also what the challenges are that professionals are facing. Some of that is picked up in the report in terms of the early surveys and the things that people have found specifically around self-harm. But we have something called the Local Transformation Partnership, which is specifically around mental health. It has partners from across the council, including youth services. We have schools represented at it. We have voluntary sector organisations, the HCP. There's a whole range of partners. And that partnership is to share that best practice that we're doing across Medway and Swale, make sure everyone's aware of the services that are available, but also come forward with the challenges and then creatively think about some of the solutions that we might be able to put in place. And some of the services that we've have commissioned have been shaped through that engagement with those professionals, as well as feedback for children and young people, looking at the data, looking at the caseloads within services. We also have a mental health leads network, and that's a specific network for schools, and to be able to support schools around understanding the services, but also having training and being able to have that peer support across schools as well in terms of what's being presented. So we do as much as we can, do a lot of work to ensure that we're working in a joined up way. Also, what we have is sort of coming right from that preventative approach through to the very specialist services that are talked about in this paper. We have the child health team within public health who support schools with PSHE and relationships and sex education. And alongside that, there's a significant amount of training that's available for schools around self-harm, around mental health, but also for children and young people in terms of mental health first aid training, Connect 5 training. And they deliver these workshops to parents as well now, so that we're getting out to as many residents across Medway as we possibly can. So we do try and work in a very joined up way around this. I think your specific questions about the evaluation of youth services and the programs that they're delivering, I'm sure Kelly would be happy to.
Thank you, Ailish. So I've just pulled up a paper that we completed in February reviewing the Reachable Moments projects, and if the Chair will agree, I'll happily share the paper so that people can read rather than me try to summarise the 6 pages of it. But it's a collaboration between Medway Hospital staff and Kent VRU, Kent Police and other professionals, and is led by our youth service. And what we know that is in between January 24 and December 24, we engaged with 402 young people that entered A&E, or 402 engagements, sorry, with 348 young people that went into A&E. And we've drilled down into what that cohort looks like. So I can tell you that 63 of those individuals were from not in education or employment or training, and we're continuing to evaluate the programme. I think what we found is that to really understand the impact, we've asked our young people that are involved in the programme to provide us with some information about their engagement and undertake surveys with the young people around whether the intervention is helpful for them. But as I say, I'm happy to share the report and so people can read it thoroughly.
Thank you, Kelly. We'll take that as an action. Simon, please.
Yeah, thanks very much, Teresa, and thank you very much for the report. It's a brilliant report, but it's also very concerning, obviously. And I just wanted, obviously, we know that our question around the statistics and the figures really is really that we know that every child's story is unique to that child as to why they end up in crisis of this sort. But one of the couple of the figures there you talk about in part 3 of the report about 15 to 16-year-olds and 13% have been found to self-harm, but maybe up to 30% with the mental health issues, that kind of thing. But that's a huge amount of children. And is it that they're coming up to that age and then it's starting, or is it? It's not very clear about how that works. I'm also conscious that's an age group that was just reaching 10 and 11 years old 5 years ago in COVID. So are we seeing a COVID issue here? It's not very clear about how that works. Conversely, the report goes into a lot of detail about causes and issues like that, which is brilliant, and the professional approach to this is really clear as to what those causes, but there's so many causes, if you like, that it's a really complex. How do you, out of that 30% or 13%, how are you unpicking those figures? Because you've got that unexplained spike that you mentioned in the report, but also further down in the report under the self-harm project, there's some data there about surveys. 95% professionals providing insights, 76 surveys complete, and the focus is 42 children, young people and adults. That doesn't strike me as very many people participating in that kind of survey. So I'm worried about the data, so some reassurance around that. And just to follow on from that, picking up on a couple of issues, I think there's connections here between the report further on in the meeting on obesity. And in that respect, I was curious about how we, obviously, a big factor in there, and it's been mentioned and it comes out strongly, it's about the young people's social networks and how they interact, about social prescribing. I'm not suggesting through GPs, but generally through the profession, how we get a greater level of social connection going. And on a personal note, in my own area, is about the access to outdoors and activity and the benefits of, say, city farms and stuff like that for children of an earlier age. So when they reach 16, they're not going into crisis, if you like. So it's a complex issue. I appreciate that. So there's 3 little areas in there. Thanks very much.
Thank you, Councillor Curry. It is a complex issue, absolutely. I think in terms of the 15 to 16-year-olds, I wouldn't like to definitively say it is or it isn't a COVID issue. What I would say is you're starting to get into peak exam pressure around that time. And so I think a large proportion of that could be that peak exam pressure. And certainly we would look at the referrals that are coming in. It does show a picture that a lot of it is around that sort of pressure, but also relationship breakdowns, things that are going on there. There's always a question of resilience, isn't there? And some children can breeze through their exams and they don't have the same sort of pressure. Some children will have a breakup and pick themselves up the next day and carry on, and other children won't have the same resilience, and it might affect them in a very different way. So to say whether there was something going on earlier on is very difficult to be able to really unpick. I think the important thing for us is to make sure that the services are available right from a young age. And that can be more challenging to get the appropriate services in for those primary school age groups and thinking about how young people are understanding their own emotional well-being and mental health at that stage. But that is what we are doing. We are commissioning services across the whole scope of that. And I think that's where the early intervention services are so much more important, because I think it can be quite daunting even for a family to think about referring their child to CAMHS. Might feel quite daunting, but I think a lot of schools themselves now tend to have therapy services, anger management services, things like that within the school themselves, and families might feel less intimidated engaging with that sort of service than they might with CAMHS. So for me, the importance is about having that early intervention supported in earliest levels, so that if there are concerns, be that from a professional, a parent, or the child themselves, they can access that support quickly and be able to build up their resilience for future life. What we know about mental health is people's mental health improves and declines, and it's about being able to get the strategies in place to be able to identify if your mental health is declining again, and then have the strategies to be able to address that. And become self-reliant, I think, is really important as well. So it's about making sure that they're getting the right sort of therapy, that they can then manage themselves as they go through, but that the services are open so that they can access them when they do need them. In terms of the survey and the data that we've gathered for this, it's a challenging topic, as we sort of spoke about. It was very difficult for us even to get the focus groups together and think about how we could engage with young people without that re-traumatizing young people, without them feeling anxious about being able to engage in that and tell us about their experience. So the cohort is small, but we had to be very careful about how we were managing that, and also who was willing to engage in that and give us the information around it. So I don't think, you can say conclusively we've cracked it through the survey, but I think if you look at the themes that are coming out, they're probably not surprising in terms of what we do understand. So it probably is representative of what we think probably is the underlying issues for children and young people when it comes to self-harming. In terms of access to outdoor and thinking about that, green prescribing, blue prescribing areas, 100% preaching to the converted here. Absolutely, I think that's what we should be doing. I think it's really important that young people understand the importance of exercise on their mental health. They understand the importance of the 5 ways to well-being and how they can maintain their own good emotional well-being through keeping active in those areas. And it's upon us to make sure that their environment allows that for them and that they're able to access that and be able to engage in that in a meaningful way. So agree, I think.
Thank you, Sam. Before we come to the next question, just a couple of reflections. I must say I was impressed when we had the Children's Mental Health event at the Corn Exchange, how well they understood the 5 ways to keeping your well-being. Lots and lots of children mentioned it. So I think, you know, all of the things that we're doing that are inherently good in themselves, whether they're related to mental health or not, are making an impression on children, which is good. And, you know, for 15 and 16-year-olds, I do think, you know, Simon, I believe that there is an impact of COVID on, having seen it with my own eyes for my own grandson, who, you know, anyone who was in year 7 when COVID hit missed most of it. And that is a huge thing when you're making that transition to secondary school, and also often missed the things that go on in year 6, like going on a residential and learning resilience. That group of children did miss those things. And of course, you know, the secondary school truck goes sort of pushing ahead and they couldn't get them back. And that same grandson, I've got his GCSE timetable. He's got 32 exams. There is something that needs to be done. That has got, in my view, as a teacher, completely out of hand. Starting almost immediately after Easter, and mums and grandparent around the table nodding, you know, that is too much. It's too much for me to sort of cope with and make sure I play my part in all of the revision and organisation. So I do think if we send a message to government, and I know that Bridget Phillipson is looking at this, it's a message about the way that the GCSE curriculum has been dissected into technicality beyond belief, and leach the enjoyment out of lots of subjects, I'm afraid. Anyway, thank you for your question. Simon Malty, please.
Thank you, Eilish. Really comprehensive report, and a lot of my comments have been already addressed. My one offer of help, I was looking at the Appendix 3, which has really helpful hints for multiple audiences. So I just wondered if there is anything that you'd like to hone into healthcare professionals, and if it can be separated out, then I can look into channels of how we can promote that in Medway health area. So it's just an offer of help. Thank you.
Thank you very much. We'll take you up on that. Tracy, please.
Thank you. I want to start off by saying that when I've been out in secondary schools in particular, I've had some really positive feedback about the Illumina training, that the support they're able to put in for young people has greatly improved because of that training. But also, in fact, primary schools are starting to be feeling a need of that. I spoke to a family liaison officer in a Gillingham school recently who said that she felt that some of the pupils at that age would benefit. So, you know, perhaps it's something we need to be looking at a bit lower down. What I wanted to talk about, though, was one secondary school in particular who's done the Illumina training, running groups, is saying that the children who are attending those groups is a fraction of those who would be self-harming in that school, because many of them won't come forward publicly and won't identify. So I think it's really important that they know about all the services and support and resources that are on offer. And we're thinking that some of these young people think they can only access this in crisis. So just what approach are we taking to make sure that the communication is improved, that young people understand that they can come and access these services at an earlier stage before they reach that crisis point, so that they are helped at an earlier stage so that things are not getting so bad for these young people?
And before you answer, Ailish, I mean, absolutely right. I've done some work in conjunction with Councillor Lawrence at a primary school in my own ward, and it was very clear, actually, how much the teachers appreciated just knowing that those services were available and that there was someone to kind of share the challenge when some of these things come up. And I do definitely think there's more that we can do. Eilish, please.
Yeah, thank you very much. It is, you know, possibly, and not just in mental health, I think in a lot of our public health services and probably other services across the council, our biggest challenge is how, as much messaging as we do and as much comms we do, how do we get the message out about the range of services that are available? There's some very specific things that we have done, for example, developing the I Thrive directory. So this is a directory now that all schools have got access to, social care has got access to, youth services and others, that they can put in the child, the area that the child lives in, put in what they think the needs of the child are, and it will then say, here's the services that are available for you and for this child in this area, and exactly how to access them, and the referral mechanisms into those services as well. We've also done an awful lot, as I said earlier, through our local transformation partnership and also our mental health leads networks to try and increase the understanding of professionals around children. But we also work very closely with Medway Parent Carers Forum to ensure that they're able to signpost families and raise awareness. And there's things we do like the mental health conference for children, which is both primary school and secondary school children, to help them understand the services that are available, as well as trying to upskill some young people within schools themselves. As I mentioned earlier, around mental health first aid training. We've got some health champions within schools as well, young people trained up as health champions. So there's quite a lot we do try and do, but I do think actually moving towards this therapeutic alliance now, where there's a single front door into services, will mean parents, children, schools, whoever, aren't having to go, okay, well, which one is the one that meets the needs of this child, or even what are the specific needs of this child, but are able to go, here's a child, and then the service, the Therapeutic Alliance, will be able to go, okay, this is the best pathway for this child, and we'll be able to support them and take over from there. I do, it's my expectation that that will help in some ways, so it's not such a difficult landscape to navigate.
I think that's absolutely right, actually, but thank you for your question, Tracy. It's an important one. Tass, please.
Thank you. I just wanted to echo Eilish's point there about the engagement. Having worked on the engagement for this project myself, there were definitely that sensitivity in those issues that came with the project, with the topic of self-harm, and getting people to talk about their mental health, let alone a subject like self-harm. Not everybody wants to talk about that. So I think a very good job. I think the numbers there are pretty good. What I just wanted to say is that, picking up on Councillor Curry's point, there has been engagement done with our project partner, IMS, who sits under MVA, who have done more engagement for this project with young people and children. Those numbers will be reflected in the final report, so there'll be more there for you. Thank you.
It's helpful to know. And finally, Andrew, did you want to come back on?
Thank you, Chair. There was only one point that really occurred to me, is given the fragmented nature of the services, is how we're sharing data, so that if young people are accessing different service providers, where's the dots being joined up? And that may be something you might want to think about when you're commissioning new services, to make sure that not only do we have one point to obtaining treatment, but maybe one point to storing the data as well. Thank you.
Yeah, absolutely. And that, so the Therapeutic Alliance will have a single database. The Therapeutic Alliance will be for that low to moderate. The ICB will still be commissioning specialist CAM services across the whole of Kent and Medway. What we are, both us and Kent commissioners, are looking at this as still a single pathway, and with CAM services dropping down into the Therapeutic Alliance, so actually having staff sitting in the Therapeutic Alliance, being able to discuss children, discuss cases, and share the information around that. We're doing that at the moment, actually. So our short intervention therapy service, for example, will work alongside CAMS and take some children off that caseload and support them. And CAMS will also, when a child comes in and is referred, if they say they don't meet the criteria for CAMS, they will refer them specifically to the other pathways that are available. So whilst there isn't necessarily a single shared database across those services at the moment, there is definitely shared working practice to ensure that children are picked up by the most appropriate service.
Thank you, Ailish, and thank you, Celia, and all the contributors. Very important report, and I'm looking forward to the Therapeutic Alliance, actually. I think it is going to make a big difference, and I think perhaps there's a recommendation from the committee, if others agree, we'll make sure that it gets sent to the Children and Young People Scrutiny Committee, if it hasn't been already, because I think it's really important for all members to understand, and for us around the table to be ambassadors for this, and to make sure that we, like Malty, taking you up on your offer to promulgate that information, absolutely, we should be doing that on all of our networks. So you've got the information there, and it would be very good to know that happens, please. So thank you. With that, then, I'm going to move on to having asked you to accept the recommendations, okay, which is really just noting, but we've got actions out of there that I think sort of, make the recommendations stronger. So if that's okay, thank you, everybody. So I'll go to item 5B, which is vaccinations and NHS immunisations programmes. We had a very good discussion about this at the pre-agenda for this committee. We are an under-vaccinated population in Medway in any of the vaccinations that are on offer. So we're going to hear from David now, and hopefully from other people, about what we can do to improve that. Being asked again to note that, but open, please, to ideas about improving take-up from anybody, please. Thank you, David.
Great, thank you very much. So this paper gives an overview of the importance of immunisation and vaccination. It gives an overview of how the system works. It's quite complex, and also identifies some important areas for us to focus on locally, in particular MMR in children and flu in both children and in adults. Immunisation and vaccination is extremely important for protecting population health. We've seen incredible improvements in health with the introduction of vaccines, and it's really important that we keep vaccination rates high. For a number of vaccines, we need to try to maintain herd immunity, so get enough of the population vaccinated so that it then protects the rest of the population, particularly important for things like MMR, where we are currently below the threshold that we really need for herd immunity. And we're starting to see in some parts of the world where anti-vax sentiment is quite strong. Parts of the USA now with seeing outbreaks of measles. Children are dying as a result of anti-vax sentiment and not achieving high enough levels of vaccination, immunisation. The system itself is quite complex. In the reforms of 2012, responsibilities for different parts of vaccination were given to different parts of the system, different organisations. So it is a little bit complicated. The main commissioning is by NHS England. Within Kent and Medway, we have KCHFT delivering a portion of the childhood immunisation. We've got delivery also through GP practices. Local authority public health responsibility is largely one of assurance, and we have a health protection board, a Kent and Medway health protection board, where we conduct our assurance role. It's a multi-partner board, but that's where the directors of public health get their assurance regarding the delivery of the immunisation programmes. We don't, I believe, have colleagues today here from NHS England, unfortunately. We're hoping to have representatives from the screening and immunisation team here to answer questions. So there may be some questions that we won't be able to answer that we have to take away to that team. But I can tell you about some work that we have planned coming up over the next sort of 6 to 9 months, focusing on MMR and in flu. We're going to do some insight work to try to get a better understanding of why some children are not getting vaccinated, and try to develop some programs to promote vaccination with MMR. And with flu, we're going to be looking at not just looking at children, because they are known to be important spreaders of flu during the winter season, but also looking at health and social care workers and their views on immunized flu vaccination, because it's really important to try and get the health and social care staff vaccinating to protect the people that they're working with, their patients and their clients, but also from a very sort of pragmatic, practical point of view, it helps the system if we have fewer people who are off sick in the winter with flu. So I'll finish there, just a brief overview of what the paper's about, and happy to take questions where I can, and then take others for NHS England colleagues when necessary. Thank you.
Thank you, David. And for assurance, obviously, if there are questions we can't answer, we will definitely get them answered for you. And I think, you know, this anti-vax movement is problematic. There's a lot of rubbish talked on the internet about vaccinations, despite the long time that we've had them as a very demonstrable way to achieve public health protection. And I think there is more we can do in our family centres, definitely, to encourage the take-up amongst 2- and 3-year-olds, not just for the protection of children, but also because they're super spreaders, for the protection of everyone else. And we have seen a terrible winter in the hospitals, overwhelmed in some cases by people who had flu, many who were not vaccinated. And in the end, at our local hospital, they had a pop-up vaccination thing in the foyer trying to encourage visitors to be vaccinated, and indeed staff. You know, it is not the case that NHS staff all take up vaccinations. So we've really got to do some myth-busting. I think one of the things about the influenza vaccination is, because it's not like COVID, it doesn't stop you getting it, but it manages your symptoms. And I think because of that, people think, oh, it's not, you know, worth having them because it won't stop me getting, I might still get the flu. But in fact, the difference that it can make is immeasurable, particularly to anyone who is clinically vulnerable. So I'll open that up for questions and mainly ideas, actually. One of the things I think we should be doing is going into trusted spaces in the community to give vaccinations, not just relying on people coming to get one. I think there's been quite a lot of work around the country on that has been successful. So I'm hoping to have a push on that, and locally some work with the pharmacy has started with colleagues from the ICB who've been to visit. So I'm looking forward to that. Simon, please.
Yeah, thanks very much, and thanks very much for the report. It's hugely important and frustrating when you hear about the people who won't take up the offer of free care, if you like. I mean, it's there free at the point of call to make you not get sick, which is key. And I just, you mentioned actually about the safe places and where people can get the right information, and the report talks quite clearly about this is an education side of thing, really. And one of the key areas is places of work. And I'm just wondering about the connection with major employers outside the health service, certainly within the council, obviously, but also other major employers like BAE and other organisations, and how much connection we have with them about dissemination of the information. Because by far the most of those people in those employment spaces are also parents as well. And getting that information through employment might be a way of achieving it. You may be doing it already, but I'd raise it as an issue. Thank you.
David, please.
Yes, so that's an interesting idea. So we don't currently do anything like that, so no proactive programs with large employers. But it's an interesting idea. Yes, we'll have to have a look at that and see whether we think it could be effective.
Andrew, please.
Thank you, Chair. Simon, I think it's worth noting that 90% of people employed in Medway actually work for companies of less than 10 people. So actually, we do need to find some routes into accessing that 90%. And, you know, maybe there are other places where individuals touch public services like DWP, for example, our housing office. All of this is places for people to receive information. We could even put it on our council tax bills. Chair, for example, have you been immunised, for example? Not that anyone would want to open their council tax bills at the moment, but anyway. I was interested in there was no demographic, no data around take-up amongst different groups within Kent and Medway. I think that's a very important piece of missing information. And so maybe the next time we get this report, we can have some more information, because we do know there are different take-up rates amongst different groups. And also, I suppose if we're really serious about health inequality, also the take-up amongst people who live in different demographic groups as well. So I think that was missed in the report. I was really surprised I didn't realise that we were actually immunising 2- and 3-year-olds for flu. I totally missed that one. Just on a point of information, absolutely understand that young children are super spreaders. Who hasn't caught something from a child who's just started nursery, for example? But does it actually stop them spreading influenza, or is it just manage their own symptoms so it's less of an impact on the person who actually catches it? Because the anti-vaxxer point, Chair, is a really important point. I think but the problem with it is what happened during COVID is the real root cause of that. There was a lot of misinformation about the benefits of the COVID jab, and that unfortunately turned out to be untrue. And I think we need to reflect on that in terms of our information, what information we put out there. So just on that point about children being immunised against the flu, does it actually stop them giving someone else the flu? Because then that goes, if it doesn't, then the super spreader argument doesn't really work. Thank you, Chair.
David, thank you.
Yeah, so yes, it does. So the major point of vaccinating that group is to prevent them from preventing spread to other individuals. So yes, it does.
And just quickly on what you said about cultural beliefs influencing not having a vaccination, that's absolutely right. And the Diversity Forum would agree. And in fact, Rupa Sen's been one of the people who has really been keen to work on getting vaccinations in trusted places and getting the information out there.
Thank you. I was interested to read in the report about some vaccinations, flu vaccinations, being given in a nursery setting, a preschool setting, and that parents were very accepting of this method of delivery, and that was going to be rolled out. But not all children go to preschool and to nursery, so I just wondered if there was a role for health visitors in delivering this, if that might be a way to reach those young children who maybe don't go to a preschool or a nursery school.
Yeah, I'm happy to pick that up. So there could be, but it would need additional investment, I think, is the challenge. And so it would be about the NHS England. So currently, as David said, they commissioned KCHFT to do all those school-aged vaccinations. GPs deliver the under preschool-aged vaccinations. So either we would have to make a decision about what we wanted health visitors to stop in order to start doing the vaccinations, or it would have to be a discussion with NHS England to say, we can improve this, but you'll need to do some investment into the service in order for them to include this as part of the offer that they're doing at health visiting. So not adverse to it, but some negotiation to be done, I think.
But I think asking the question, particularly of MCH and KCHFT, about the role of health visitors in this, even if it's an advisory role, I think that would be...
Sorry, I should have been clear. In terms of an advisory role, that is absolutely part of the health visitors. So they will be having conversations with families as part of the regular 5 mandated checks that they have to check, are they up to date with their immunisations? Do they know how to access them and where to go in order to be able to get those? Sorry, I should have made that clear.
Yeah, I get a feeling with deja vu about this chair, because it goes back to my early days on the county council back in the 1990s, and the work that we were then doing in the Borstal area, because we discovered that there was a group of children on a local housing estate near a primary school who weren't getting vaccinated. And I mean, I suppose the answer to the director's question when presenting this report is that we have to drill down to particular neighbourhoods and look at particular situations and circumstances. The value of primary schools, working with local housing associations, as was in this case, taking over an MHS flat for the purpose of the project, improving the level of and take-up of vaccinations. I realise it's resource intensive from that viewpoint, but of course the reward is great. So, I think it comes back to the old sort of joined up working schools, housing associations, local authority, local health authority, and so on, looking at particular neighbourhoods and particular areas. Thanks very much, Chair.
Thank you, Mark. Memory lane is always worth a trip down. And in actual fact, you know, you're absolutely right that to some extent there's nothing new under the sun. But I think at that time, we probably wouldn't have had this anti-vax lobby being quite so prevalent, or at least if it was, it didn't have the same level of communication outlets. But you know, a point very well made. David, can I ask you, have we got public health intelligence on the neighbourhood take-up? And if we haven't, could we think about that happening and perhaps being added to our ward profiles? Because I think they're a really very useful and accessible way for us to look at the reach and impact of some of the strategies that we've got in public health.
Yes, so for quite a long time, we haven't had much access to granular data around immunisations and vaccination. However, the team has fairly recently been able to get access, so they are developing some work. And yes, you're right, we could think about including it into the ward profiles. But there is, as I mentioned earlier, there is this specific piece of work that we plan to do over the next 6 to 9 months, looking in quite a lot of detail at, in particular, MMR and understanding why there's low uptake, and that will involve identifying the areas where uptake is particularly low, and then going in and having conversations with those communities to understand why they're not getting vaccinated.
Yeah, for the board, we're wanting to use the Health Determinants Research Collaboration to really get a very granular view on this. Kelly, please.
Just to share, I'll take up your point in respect to the family hubs to ensure that immunisations are well promoted and that our practitioners have the right information and to provide the advice needed and signpost to the appropriate services, and I'll take that forward.
Thank you, Kelly. So, yes, please, Louise.
Thank you, Chair. I suppose I just wanted to pick up on that last point about actually understanding why people choose not to either have vaccinations for themselves or for their children and young people, and whether that varies between different kinds of vaccinations. So it's almost understanding what the issue is, how we might best tackle it, where do we message, how do we change that narrative, and just to echo Ailish's point, the role of the health visitors, and in fact anyone working with children, with families, and particularly for some of the vaccinations with older residents, about actually making sure how they can get vaccinated, where, when, and supporting and promoting that. It comes back to that every contact counts and getting those messages out in every contact. So something very much as MCH we're committed with our staff to doing.
Thank you. That's good to hear. So, okay,
Just
Andrew.
one more point, Chair. I just wonder if this is a generational issue and whether non-take-up of vaccinations goes from generation to generation, and is that something that we should also be tackling? Thank you.
Yes, I mean, I think that, you know, that's as valid a point of any of them, but I think I don't remember people either in my childhood or when my children were young being, I don't remember that the reluctance that does seem to be prevalent here. You know, people turned up and had their vaccination, and there wasn't an argument about it. And I think, you know, we have seen the rise of measles again as a result of this, which is absolutely, you know, shocking because it is a very disabling disease. Did you want to say something else?
Yeah, I mean, my own recollections is much more was done at school level. So you didn't have to go to the doctor. I clearly remember having my polo on my sugar cube at school, and I wonder whether that we've moved away from that strategy, I think, to a certain extent, and whether that's the strategy we should be thinking about moving back to if we haven't already.
Coming back, please.
Yes, so not specifically on that point, but on your previous point about a generational issue. So it could be a different kind of generational issue in that in sort of earlier generations, people were much more aware of the harms of things like measles, etc. And now we haven't had it for so long, people have become complacent. Yeah.
You know, all the contributions, they're very valuable, and obviously, Louise, for MCH, a critical part of your work, particularly with the health visiting service. So I think in accepting the recommendations, we've got several ideas there that will encapsulate as actions. And David, if we could have, in the fullness of time, some kind of public health intelligence report on vaccinations, either just as a briefing note to the board or maybe bring it back to have a closer look at. We'll see what it looks like when we get it. That would be helpful. And looking forward very much to the MMR piece, because that's critical to determining the way that people behave in the future, isn't it, if we can do that. And, so thank you. Good discussion there. So everybody happy to accept the recommendations with those additions? That's it. Nods and sort of murmuring. So I'll take that as a very good thing. More murmuring. We're going on to item 5D now, the NHS cancer screening programme, breast, bowel and cervical. Very topical at the moment. Oh, sorry. Oh dear, I'm flashing too fast. Obesity's first, we'll come to that. That's important as well. Okay, Scotty, you're doing this, yeah.
Thank you, Chair. So obesity trends are not going in the way that we'd like to see. We do have an upward trend in the last year, which is counter to the targets we've set in our Child Obesity 5-year plan. In reality, tackling obesity is not an unresearched subject. There's 3 pretty recent documents listed in section 4, which are relatively hot off the press. So the evidence base is quite clear around what does work. The NICE guidance is pretty comprehensive and points to evidence which many of us might think are common sense around children walking to school, access to green spaces, healthy food environments, etc., etc. But some of the documents do bring some new points to the table as well. The blueprint, the Nesta blueprint document for itself, really emphasises the need for national interventions as well as kind of local action, which is really positive. Locally, we have made some good progress on many of these sort of nice recommendations which are listed in section 6. Got quite a comprehensive array of interventions. But the fact that the data is going the wrong direction maybe suggests we haven't achieved the scale needed for the desired impact. Our whole systems obesity network is, continues to keep growing. We have a really good amount of people engaging in the network around the subgroups. So, decent comprehensive list of existing interventions, which are largely delivered by a wide range of partners. It isn't just the work of one council public health team. But we have identified some absolute gaps in section 7, which a variety of board members can contribute to, so that we are compliant with the evidence base. So yeah, just bringing an update report to really discuss where we're up to and as we move forwards.
Thank you very much. I mean, I think, Scott, one of the things to say, as you can see in section 6, we have got a lot of things going on that are intended to tackle this problem. One of the issues that we've got is lower take-up than we'd like, particularly to things like the cookery classes, which are great, free whole family events, but proving a bit difficult to recruit people to. All of the things that we do under the banner of A Better Medway and our Food for Life and food strategy, really trying to get sustainable, wholesome food that is accessible to everybody and, work with people to know how to use it. So I'm really interested in any ideas in the board, because we want this trend to go back up again. And very much this is part of our One Medway approach, Simon. Some of the things that you said earlier in the meeting about access to green spaces, about the active travel strategy, all of these link in with this issue. So I'll open it up to questions.
Yeah, thanks very much, Teresa, and thank you very much for the report. I just think this is going to be a report that we see frequently at this meeting, because the issue is so important. I mean, we see the consequences of obesity in every aspect of our communities, if you like. There's a couple of things. Obviously, I won't go down the green space route again, because I've done that already today, but thank you for mentioning it. I think one of the things that I would say, though, is that the particularly paragraph 6.3 of the report talks about the importance of active lives and the range of things that we've got going there. And again, just to mention, you mentioned about food and active lives, just to let colleagues know that we literally met this morning with the Allotments Federation, talking about expansion of our allotments programme and getting a lot more people out there growing food and also working outside. So there's some work being done. It's not very impactful, but over the long term it will be, and it's going to grow quite a lot. So we're doing some positive working there. I think the other thing is, and Teresa mentioned about the One Medway Council Plan, is the link this has with so many other aspects of Medway's life. And we mustn't lose sight of the fact that this is connected up. And one of those areas, and part 10 of the report talks about the climate issues. And I think this is hugely important, and I'm sure professional colleagues understand this, is about the impact of air pollution. And one of the things that we're trying to do as quickly as we possibly can, and are starting now gradually to see some signs of improvement, is about the quality of air, particularly for our young children. If a young child has compromised lungs from air pollution when they're growing up, and therefore they stop being active because their lungs aren't working properly, they're going to put weight on, and that's with them for life. And now I think we're seeing the consequences of that in our adult population at the moment. And we have got some serious, we've got 4 air quality management areas in Medway. We should have 0. And that's a massive thing that we've got to try and tackle. So the link here between quality of our environment and the quality of our health is absolutely writ large and very obvious. So anything that goes around air pollution and the impacts of it are really important. And I know that David's been working closely with the community in Rainham and the Rainham Eco Hub about the Medway Breathes project, looking at the number of children using inhalers. And it's really high, isn't it? And it's quite a serious problem. And that's the sort of consequences of bad air resulting in bad lungs for young people. And I think that's something I really want to stress. I can't talk about it enough, to be honest, but we're doing our best. So thank you, Chair.
No, really important point, Simon. Andrew, please.
Yeah, I wonder whether there is a solution to this problem other than keep trying. And for officers, it must be quite demoralising given the amount of work you are putting in, and then you see the data going in the wrong direction. I really do think that this is about personal choices. I think people just make the wrong personal choice when it comes to the food they eat. But if you've got a McDonald's, a Burger King, a KFC, and other fast food restaurants are available on your doorstep every 50 yards, the choice becomes overwhelming. And I wonder whether we can use the planning system to limit, especially now we're going through a local plan process as well, that we should be limiting it. Then we talk about deprivation as an impact on obesity. And you've only got to drive down Luton High Street to see, it's almost, it's terrible. I do think this starts with education. I think it starts with the quality of food at school that children can have access to. I think it's making sure that choices that children are given are the right ones. I also think it's something about school curriculum. The physical education thing seems to be very limited, and yet a lot of our schools in Medway have got good green spaces where we could be doing more activity. I applaud officers' hard work in this area, but I think until people make a conscious decision to eat better, I think this is going to be an uphill challenge. Thank you.
Thank you. We've got to push them in the right direction, and actually using the local plan to do that, I think, is something that we definitely can do, including, preventing some of these other outlets now that have started to sell unhealthy food and alcohol in strange situations, like B&M and Savers have got, wine and spaghetti hoops in the middle of the deodorant and the cotton wool. So it lowers the consciousness of people buying food and thinking about what they're doing. And I think we've got to do everything that we can. There is some great work going in schools through the Food for Life programme I've been to, including some curriculum training, actually, linking growing food, cooking food with the science curriculum. And I think we do need to absolutely continue that, even though the funding for that is, we're coming to the end of it, aren't we? But got to think about how we can incorporate that good practice into other things we do. Celia, please.
Thank you. And I was also going to challenge you on the schools doing work around exercise. It is built into the curriculum. Most schools do more than the required amount, and I'm always pushing this. I was going to make the observation, really, quite interestingly, the Nuffield intervention ladder, and we do a lot of activity that is at the bottom end of that. So we are passively trying to persuade rather than actually calling out. And you know, obesity and talking about obesity is really difficult. It's especially difficult with young people and all the connotations. So you talk about a healthy lifestyle, you talk about being fit, but we're measuring obesity. And so, you know, I don't know the answer. I'm just wondering whether there's more detail in terms of a targeted approach that we need to think about, because whilst they all impact on obesity, obesity is one measure. Are you measuring how healthy people are and how much exercise they're doing? No, we're measuring how obese they are, but actually we're trying to change that with other factors. So it's just a challenge really to the group to say that there's a bit of a disconnect because we shy away from telling people they're obese, but actually we're measuring it. So
I'll just come back on a couple of other things really. Really with the local plan underway, as you mentioned. So literally this morning, I was just started the document that's going to go with our guidance note around our T27 strategic policy around health and wellbeing for the local plan, and we're going to be really specific. So we've looked at every single local plan guidance note that talks about restricting new hot food takeaways, and we'd like to be super ambitious. So what we need to have is full member support from all sides and all directors to kind of go, yeah, this is the right thing to do, because that will give it its best opportunity when it goes to planning inspectorate as they go approve all your local plan. So we intend to be super ambitious, so everybody's support around that to say, yes, this is the right thing to do for our children, because in reality, eyeline is byline, and when we went to the ICP meeting last month, there was a reference there around parents. You know, parenting needs to be better, needs to be stronger. This didn't happen back in the day, but in the 1970s and 80s, we didn't have the environment we're in now, the food environment we're in now. So you cannot compare the apple with the pear, because a few more apples and pears would be much, much more beneficial than another hot food takeaway. So we can definitely limit the supply, but we can't get rid of some of the existing ones. So we need to do a kind of another range of measures there. But equally, the food environment should not be blamed on these hot food takeaways. How many people in this room here have responsibility for catering contracts within care settings, within hospitals, within green spaces, within there? So if we get our own house in order and make sure that they are in there, and we normalise healthy, sustainable local food, again, we have a much better chance of encouraging our more commercial partners who naturally need to kind of return a profit to their shareholders as well. It'd be great to swap some of those 32 exams for a bit more school time, wouldn't it? I totally agree. We do have 42 schools signed up for our Food for Life programme of 100. We will be writing to all those schools to say we're going to carry on paying your licence fees so you can keep working towards that award criteria. That's part of the legacy of that project. But Medway has some of the best access to green spaces. If you look at our indicators, our JSNA indicators, the thing we're green at is more children live closer to a green space in Medway than most parts of the country, so we absolutely need to kind of embrace that. And we have had an increase in our physical activity level for children. So we do measure beyond just obesity. So this was just a focus on obesity, but the things which enable that breastfeeding prevalence, that's gone down. So we're not doing very well with that. But children's physical activity levels in Medway went up in the last year. So that's a really positive thing. So encouragement to schools. They're doing some really good stuff. Encouragement to early years and nurseries. But totally agree with Celia. Looking at enough food intervention, that is a really important point. And again, this is what this board can do for us. How brave are we going to be to start operating at the top of this ladder? Because if you only operate at the bottom of the ladder, guess what the outcomes will be? And that's the same whether you're talking about recycling or talking about obesity or talking whatever. So yeah, really encouraging there. And obviously the other gap we've identified is a weight management gap. So we absolutely need to make sure our NHS colleagues do restore that kind of parity that we don't have at the moment. So there are people in Medway that can't access a treatment services that is recommended by NICE. New medications have entered the market. Whether we think medications are good or not, they are effective, they are NICE recommended. So we absolutely need to see progress on that.
Thank you, Scott. And I think, that is all absolutely right. And Celia, we wouldn't want the board to the message we want to send to schools is that they are trying. I absolutely recognise that, and they haven't all got the facilities to help them try. And that sort of dichotomy between a healthy lifestyle and being obese, you're right about that. We're mindful of all of these sensitivities, aren't we? So I think that doesn't prevent us from really focusing on the ways together that we can change and being ambitious, as Scott has said, about the top of the ladder. because sometimes, you know, we'll resile around the bottom softer things, won't we? Because from a very well-founded thing, you don't want to hurt anyone's feelings, you don't want to make people feel that you're pushing them too hard. You know, absolutely understand. They're really good human and humanitarian instincts, aren't they? But we want to do the best we can, and we want to get that start right. So if we've got breastfeeding prevalence falling, that already tells us that there'll be, you know, we're storing up trouble later on. So it's about seeing all of those things in the round. But some really good ideas. So I've got Andrew and then Julia, please.
Just to, Celia, I didn't mean to imply that there was nothing going on at school, but actually we don't measure fitness in the same way we might measure educational outcomes, for example. And anecdotally, you know, I know someone who works in a school, and he says the children he looks after are not fit. They're doing exercise, and this leads a little bit into Simon's point, but it'd be great to see a project where we actually measure children's fitness over a period of time to see if actually some of the interventions we're doing improve. I think to Scott's point, I'm really pleased that that's happening at the local plan, Scott, but what we need planning colleagues to do is to make it easier to change the designation of the use of a property that has a fast food designation so it can be used rapidly for something else. Would be probably a good thing. And I think just it occurred to me that in terms of national policy, we've got a national policy where we're giving over more farmland to green energy generation, and that's a bit contrary to having sustainable food policies. I think we need to make up our mind if we're going to allow lots of good quality arable land to be turned into solar farms or wind farms. Is that helping us meet our target of wanting local food sustainably grown so we're not having to rely on lots of imported food? Thank you, Chair.
Okay. Julia, please.
Yeah, I'd like to add, what we do well is obviously measure them. You know, we do know what our rates are in Medway, and that's thanks to the health visiting teams. But what we need to do more of is safeguarding and obesity training. It's something that we offer. It is a safeguarding issue when children become overweight or obese. So my ask would be that all health professionals, schools, anybody that works with children and young people under our duty of responsibility for being responsible adults to access this training, because you know, it is important that we raise this issue, and it is important that families are aware that it's a problem, and it's building up a problem, you know, from a very early age into adulthood. So, and some other good examples of work that's happened across the local authority is, you know, the implementation of the advertising policies to ban fast food promotions on the billboards in Medway. So there's, as Scott mentioned, there's a lot of work going on. And becoming sustainable food, having a sustainable food policy is something else we're working on at the moment, so that when we are commissioning contracts, we factor all of these things in with caterers, etc., to make sure that children are eating healthy food. So, thank you.
Thank you very much. So we've got some sort of bits of innovation and pressure there. Absolutely, Scott. I think what would be good to do is for the Health and Wellbeing Board to support what's coming forward from public health to planning for the local plan. I think, you know, the more representations as we come up to Regulation 19, the better. And, you know, there's a balance to be struck, isn't there, with things like growing food as against doing other activities. But I think they're a really helpful discussion, facing up to a problem that's there, and one that we won't stop working on. And actually, it is nice to be able to say that our food strategy has been nominated for an award, and we'll be going along later in the year to see whether we've won it. So, you know, it's about being ambitious and not giving up, and absolutely I know that the public health teams don't, or always coming forward, as you've told us, Julia, and that's helpful, with lots of ideas. So with all of those ideas encapsulated, is everyone happy with the recommendations? And I will move on to cancer screening, breast, bowel and cervical. And at the moment, this is very topical because there is a very live debate about introducing screening for prostate cancer as a mandatory screening alongside the other ones. So, David, you're going to take us through this.
Actually, I'm going to pass this one over to Scott, if I may.
Thank you. So your screening immunisation team have sent their apologies, so I'm just going to attempt to introduce the paper on their behalf, but won't attempt to answer any of the questions. I'm not an expert, and I'll hand them to Dr. Andrew Stradlin, if that's okay. The paper provides an overview of the three specific tumour sites and particular screening efforts, as we're performing worse than average for breast, bowel and cervical. However, all of the cancers that do have screening as a core part of their pathway do have similar barriers to uptake. So if you think about improving capability, improving accessibility and improving motivation for screening, that is ultimately the quick answer, but obviously the long answer is much more complicated than that. This is a complex space for cancer screening. There are quite a few partners which operate in around the pathway. Section 3.4 onwards gives some good information of these partners. We have important roles from NHS England, from Medway Cancer Alliance and our own health and care partnership. We've got Nicole here today, who's happy to answer questions on some of the important engagement work they do and some of the important work they started with NHS England on specific inclusion health groups. Had some really fantastic listening events more recently with our voluntary sector partners asked about lived experience. Because what we do see is a much lower uptake for certain demographics, so very similar to the pattern we see in immunisations. We do need a proportionate universalism approach to really improve uptake for these three specific tumour sites, but I don't want to get distracted because it is obviously just it's not worse performing. We can do better on all of them.
Thank you. Nicole, did you want to add anything?
Yeah, can do. Just to sort of say, so from a health and care partnership perspective, we're not kind of responsible for the cancer pathways and treatment, and we do work alongside the screening and immunisation team, but we have done some projects recently. So we've just finished a bowel screening project in partnership with MVA, and we're currently doing a project, again, coming back to Scott's point, on kind of engagement and actually building those grassroots kind of projects and solutions to some of the barriers that exist with our most vulnerable communities. So really understanding and giving a sense of power back to the communities to come up with some of those solutions against some of those barriers. So that's kind of the work that we've been doing in Medway as well from a health and care partnership perspective.
Okay, that's helpful to know. And I think, particularly on cervical screening, we can do better in terms of the facilities available. There are some groups who you can't access the more specialised, comfortable environment that, say, for example, can be offered at Clover Street unless you've got another problem. And, I'm afraid, for want of anyone's embarrassment, my last cervical screening experience was very recent and very unwelcome. In my doctor's surgery, the couch where you're sitting has your legs facing a door, and that door had to be locked to stop people coming in. Now, the nurse asked me, did I mind if she locked the door, which I didn't, but I could be any kind of lunatic in with her. Now, I have written to my surgery to say that was completely unacceptable. I went through the procedure. I'm very grateful to be able to have the procedure. But there are many women who wouldn't be at all comfortable with that, and many nurses, actually, who wouldn't be comfortable with having to lock the door to stop people barging into an anyway inadequate room. So, I do think one of the barriers to cervical screening is the circumstances that people have to go along and attend to. For the other self-screening things, I think there is a bit of an uptake and a bit of an improvement, as people realise that it's actually quite a simple, clean-handed thing to do. But if we're going to do better, and you can see we're behind the whole of England coverage, and it's so critical, it makes a huge difference to treatment. So I think, I've shared a personal experience. I know many people who've had less than good experiences in that same situation. We've really got to put some pressure, I think, on the NHS to make those better facilities more available. We went through this when we had the Women's Health Hub discussion, and actually nothing has changed. The commissioning is the barrier to using those facilities effectively, and it cuts out a huge amount of women, particularly from some sections of our ethnic minorities for whom, the circumstances offered at GP surgeries are just not acceptable. And as I've said, they're not acceptable to me in my last iteration, but there we are. And I think there's a failure to talk about it because it's a pretty embarrassing and unpleasant experience if you have to go through it. And I came away from that thinking, blimey, you know, could do better, 3 out of 10 in terms of that. So any other good ideas about how we can improve it? Having a decent facility and not locking the door, being, I should put that on the paper if we don't get anything else, yeah. Yes, Andrew.
Sorry, I did a very brief some research before I came here, and I was quite surprised to see that 10% of all breast cancer cases occur in women less aged 45 or under, and I'm wondering whether we're not screening enough actually in terms of the cohort. Now I know this is important from a cost perspective, but that's something that I would like to see as a recommendation from this board, that we do look at reducing some of these ages. And in those particular groups, apparently the breast cancer is much more aggressive. And it would be, so I think that would be a good thing. I think once again, access, I mean, picking up Simon's really good point about employers and getting employers to do that messaging. But once again, you know, so many of our people work in small businesses, and how do we get that message out? But I do think, you know, the council has a lot of touch points with its residents. Every time there's some form of communication goes out, we could be putting messaging on that communication. We could run our own regular social media campaigns as well. You know, the council, you're very excellent 1 minute Medway. You know, maybe we need to drop a few hints, even if it was just a banner running across the bottom, because they go out on a weekly basis. They would all help raise awareness. Thank you.
No, good idea, and we'll put you as the patient on that as you've done that. Malty, I wonder if you've got any reflections on this from the ICB's point of view.
From my reflections, I think the points that have been raised about understanding the hotspots and the work that HCP has already done, that's really encouraging. I do, whilst some of you know I'm public health consultant, but I'm not a public health consultant in a council at the moment. From my recollection of the age band that you have just said, that's the early intervention, and the national screening, the criteria for screening is determined by the National Screening Committee, which has a very strict criteria, and they also look at the loads and loads of evidence. So that may be something that, so the early age side of things has to be determined by the National Screening Committee as opposed to the local NHS establishing that criteria. So that would be my reflection in relation to that. But the other thing that I also want to point out is that we look at the data, but it's primarily it's the responsibility of the DPHs. So David and our Kent DPH have a look at it, as has been in the report. I make a note of the screening being delegated to ICBs in future. So that would be something that I would be discussing back at the ICB. So that is a summary of my reflections. Thank you.
Thank you, and I think that's helpful. And we'll consider perhaps at the next pre-agenda about how we probe the screening ages, because I think you're right, and I think prevalence of cancer generally is starting to be seen in younger people much more.
Chair, just if it's helpful, that I think some of these things is people don't do them in their earlier life, so they all of a sudden it comes along and they start being screened. I mean, I've been contacted about bowel cancer screening, for example, and I sit here on this committee thinking, why have I not taken that up? You know, genuinely. And it's because maybe we don't have a culture. It's towards the middle of your life that all of a sudden you start getting these things. And I don't know about you, but since I've been in my 50s, the number of people who are no longer here who were in their 50s, has really hit me quite hard in the last few years. So I think we just need a culture of screening and, you know, culture of people being in touch. And I still think GPs are the key to this. You know, I think we're missing something in all this fragmentation of services, that your GP was your trusted family health advisor. And somewhere down the line, we've lost that bit of it. You know, a bit like health visitors were also your trusted, you know, and in some of these obesity discussions, we should have reflected on what roles health visitors could be playing in terms of identifying children at risk of obesity very early on. Thank you.
Look, making every contact count is important. Andy, please.
Yeah, thank you, Chair. Just to agree with Councillor Lawrence, the fragmentation, I think, hasn't helped. District nurses, health visitors all used to be based in general practice, and maybe going back to that in integrated neighbourhood teams, we shall see what happens. What I would say is that any pressure you can put on the estates would be very much appreciated. It's the thing that comes up most often after capacity and workforce, particularly in Medway and DGS. The estates are not fit for purpose, and to have that funding to go into estates to allow purpose-built rooms with the right facilities for things like this to be done would be great. At the moment, there aren't enough rooms for the general practice staff to go into. I think the other thing, if the ICB is going to be responsible for the screening going forward, is to look at how any improvements are commissioned in general practice. The appendix for this looks at measures that could take place in general practice to improve patient experience and to get more patients into the breast screening programme, but it doesn't make any comment on how that would be commissioned, how the practice time would be funded, how the SMS text messaging will be funded, and I think that's a real fall down area a lot of the time, is that because general practice is commissioned in a totally different way, it gets forgotten that these services need to be resourced in order for us to provide them. So I would make that my plea, you know, to try and make these improvements.
No, thank you, Andy. And your point about estates is well made. We've got a ridiculous situation in Medway where the healthy living centres are emptying out because people can't afford to be there and going into a frankly inferior accommodation instead of using the excellent accommodation. So I think that is something really for us to push on, and we might consider a separate item on the use of estates, because I think it, you know, with a new health centre coming on stream in the Pentagon, I want to make sure that we're maximising the use of all of the decent spaces that we've got, and so I think having the LMC's perspective on that is really valuable. Thank you. Louise, please.
Thank you, Chair. I suppose I wanted to build on that point, because for me, part of the benefit of developing the integrated neighbourhood teams, which is what we're looking to do going forward, is actually bringing all those staff together, health visitors, district, you know, not going back to where we were, but actually working with and in communities with voluntary sector partners to really maximise those interventions that we have. So I think it is, if we put that with the shift of services towards prevention, I think it gives us a whole new opportunity to look at what our teams are doing, how they work together, how we get those messages across. And again, I think it cuts across a number of the discussions that we've had today. So for me, and I think Malty's very much involved with that from an ICB perspective, how we build what integrated neighbourhood teams with social care colleagues, with all of our colleagues are, and what they do and how they work in and with their neighbourhoods and their communities, using the healthy living centres as hubs for those communities. I think it's a real opportunity to look at how we commission and provide services going forward. So I'd be really keen to support that and to advocate for it.
Please.
Thank you. I think this is a real demonstration of the health inequalities that we've got in Medway in particular. And one thing I'd be really interested in is what are we doing to find out what are the barriers to some of our ethnic minority groups or deprived areas. Why are they not accessing these services at the levels that others are? And it's not really any good asking the people who come along for the screenings. We need to be talking to those who don't respond to the invitations and who don't make the appointments. And I just, I'm wondering if we've got any kind of action plan for trying to determine what those reasons are.
I wonder at the end if you might come in on that, because perhaps that's something Health Watch can help us with.
Yeah, thanks very much. Just picking up that point you made about accessible spaces and stuff like that, and I think there's a point that maybe to carry over to the planning team, in relation to that. I mean, I remember a situation, I think the home base up at near Rochester Airfield is now gone, but there was this great big caravan parked outside in the car park there saying screening, and I can't imagine, I know comments were made by members of my own family, they wouldn't go in there for a screening because it's in a car park. So there is an issue about accessing spaces like that. One of the things that is happening, certainly at the moment, and also within the local plan, wherever there's flats going up particularly, there's usually the space at the base on the ground floor is set aside for shops and for gym or whatever, and the community space and stuff like that. I think, and medical spaces are not mentioned in that, so I think that's a point to take away for the planning team to pick up on, so thank you for that.
Helpful. Nicole, please.
Yeah, it was just to come back on the point on health inequalities. So some of the projects that we've been delivering through the Health and Care Partnership, they have been very targeted at the communities, particularly ethnic minorities. And what we've done through that is recruit some sort of community champions to actually be our members in the community that kind of advocate for things like bowel screening and other screening programs. And we're hoping to build upon that through our sort of internal comms and engagement. But just also come back on the kind of culture of screening. It is something that we're looking very much at doing kind of some joint communications campaigns so that you're seeing it not just from Medway Council but from perhaps MCH, you know, even supermarkets do things around sort of when it's the major screening months, particularly breast cancer, for example. I know I've seen it in the local supermarket. So if we can do things as a joint campaign, then people are seeing that everywhere. So actually we can take that approach and really create that sort of culture that you mentioned.
Thank you. Multi, please.
I apologize. I just spotted an error in my own remarks. The papers say that it is a strategy for immunization, vaccination that talks about delegation to ICBs. I'll have to check it on the screening. So I just want to correct my own. I quickly checked. Thank you.
Helpful. Okay, I mean, I think we've come to the end of that item there. We're being asked to note the report and provide. There's lots of feedback and comments. And I think we will consider how we can better play our part to improve access and sort of get people taking up screening as much as possible. And on the integrated neighbourhood teams, I think everybody welcomes then. It does sound a bit back to the future, Louise. Let's be frank about that. But I think there has been a point, and I'm sure, you know, from the LMC's point of view, you would concur with this, that GPs have been sort of isolated by the formation of different teams around them, but remained the escalation route if there's something that the team can't deal with. So we've sort of tried to have it both ways. And I think if the integrated neighbourhood teams do anything, they really should be teams. And I look forward to seeing the way that they develop. Okay, with that, is everybody happy with the recommendations and the comments and notes that we've made? Thank you. So our next item is smoking at the time of delivery, please, item 5E. And we've got Julia. You were down as Julia Cox there. I don't know who she is, but anyway, it's you. So Julia Thomas, not Cox. Thank you.
Thank you. She's a colleague in our team. So,
okay.
Thank you, Councillor Murray. Yes, so this paper really has been brought to the meeting to highlight the fact that the government's ambition to reduce smoking at time of delivery, we refer to it as SATOD, to 6% or less, has not been met. The paper gives an overview of the progress to date, further actions needed to continue to bring the trend of these mums smoking at time of delivery down. As we know, it's a very important subject area because the implications are very significant and include complications such as stillbirth rates, low birth weights, and lots of other various complications. So a very important subject matter to address. This obviously needs to be everybody's business, and I think the key issue is having those conversations, as I mentioned earlier, across some of the obesity areas, and referring and signposting into services. So, you know, there's the old tale that, you know, if your doctor doesn't tell you it's not good for you, then you're not going to do anything about it. So, you know, it is all our job really to have those conversations. but also to have access to the right pharmacotherapies available to help people to give up smoking, and for any staff that don't feel comfortable and confident in raising the issue, because it is a difficult subject to raise, is to access the training. There's ample training around how to have those conversations. So whilst the trend is a downward one, and they do fluctuate on a quarterly basis, the data does rely on the midwives at the hospitals capturing the data at time of booking and at time of delivery, so at 36 weeks. So it is a challenge for the midwives under already busy roles that they have. And I have to commend MFT because they've done some great work in, getting to capture this data and to make it as accurate as possible, because across the country that's a big challenge in getting the data accurate. Reporting changes have changed. So historically it used to be by hospital. It's now from an ICB-wide locality rate. So quite difficult sometimes to pinpoint what the rates are specifically in Medway. So under the NHS long-term plan, some extra funding has been allocated to hospital trusts, and this is channeled through the ICB. And have to say Medway's doing really well in terms of its implementation. Some of the challenges for them is around job insecurity, because quite often, funding allocations are delayed, so causing anxiety amongst the trusts and the staff in terms of, job security, etc. So one ask would be that if, the ICB could support them in terms of the processing of the funding. But, it's not just, it's the whole system. So, to continue to drive this down, lots more work needs to be done, and a whole systems approach is needed to support this. So our ask really is included within the paper for each locality, each area, trusts, community trusts, etc. And then more detailed ask is by organisations, which is listed. So in terms of the whole system ask, in points 5.7 are my biggest ask really, is that that we do some more work in denormalising smoking. So this includes updating policies, challenging staff smoking in uniform, because that obviously has a consequence, passing on the carcinogens that third-hand smoke brings, and making our sites smoke-free. That would be my wish list, my ask. To champion the tobacco and vapes bill when that comes out. So that's due to be published. It's on its way through government right now. And for everybody to commit to support the 4% target by 2030. And obviously, support the financial commitment, funding, and the initiatives that come out in terms of helping pregnant women to quit.
Thank you very much, Julia, and I apologise, I didn't turn my MAPE off. In terms of the tobacco and vapes bill, Tristan Osborne MP is on that committee, so I think we need to write directly to him and remind him that part of that work needs to be thinking about smoking at the time of delivery, and indeed stopping people from returning to smoking after the birth, which obviously is absolutely critical, not just for mums and dads, but for the baby as well. And it's it can be a stressful time for families, but if the family's reaction to stress is for someone who's given up smoking to start smoking again, then that's absolutely the last thing that we need. So I'll open that up to questions, again, ideas on how we can support actually what is an ambitious strategy here to make sure that we do reach the intended targets with new legislation coming in. Anybody? Andrew.
Just a more general question. I notice lots of young people vaping, and we know that there are some issues around the vapes. Are we expecting a health knock-on in pregnancy from using certain vaping products? It's that bit of future scanning, isn't it, that sometimes we probably need to do. And I just wonder how many young people are moving from vapes to cigarettes, or is actually that's not happening, so that's one less thing to worry about. And I'm sure there is, but I was also interested to see if there was a similar report for other addiction in terms of, say, alcohol and drugs, and if that might be in part of the work plan. Because I think the knock-on effects to children, particularly from a mum who is alcohol dependent or drug dependent, is huge, and it long-lasting. Thank you, Chair.
Yeah. So absolutely right, Councillor Murray, in terms of your comments around stopping smoking after birth. So we do offer a postpartum weight management service for ladies once they've had their babies and their families. So that's something we offer. And in terms of vapes, we know that they're 95% safer than smoking cigarettes, and it is promoted within pregnancy. So that is something that the government support. They've been around for some time, so there's no evidence to suggest at this point that there's any harm, because what you're not getting is the carbon monoxide, which is obviously the harmful bit of smoking. Obviously, the nicotine is the safe bit. And yes, and there's work about to start on vaping and young people. We're also working very closely with our colleagues in trading standards, because shops selling vapes is a big challenge, particularly to young children. So they do a lot of spot checks with different organisations. And again, the new bill that's coming out and the implications in June around vape shops. So there's quite a bit going on. Yeah, and I don't know, Ailish, are you able to answer the alcohol and drugs related? Thank you.
Yeah, so there is definite work going on around other substances, both in pregnancy and also supporting children in the home if parents are using substances as well. So there's a multidisciplinary team that sits within the vulnerable parents pathway within midwifery. It's obviously a very complicated issue if a mother is using substances while she's pregnant, and it's quite a complicated care is needed to ensure that that is safely managed, and that the child, whether they have withdrawal symptoms when they're born and things like that. So it is quite a complex care pathway that is put in place around that. There is work, I think there's further work that we need to do at that preconception stage. There's lots of messaging around that there is no safe alcohol level when you are pregnant. But I think there's probably further communication we could do around that preconception stage. And I certainly know it's something that Councillor Jackson's very passionate about in terms of the FAST pathways. And we've been having conversations with her. We've done a lot of work recently, the FAST pathways, fetal alcohol syndrome. We've done a lot of work recently on the FAST pathway once children are born, and raising awareness around that with social care workers, healthcare professionals, and also having a pathway into referral for specialist diagnosis around that. But I think the preconception stage, there's further work to be done. There's a lot we're doing through the Family Hubs and Start for Life programme, messages that we can raise through that. And in addition, we've just this year are funding an additional hidden harm worker to sit within the substance misuse services and support those children whose parents misuse substances to try and reduce the trauma and the adverse childhood experiences that they experience through that process as well.
Thank you, Ailish. There's quite a lot going on, and I think just for the interest, did you want, sorry, were you coming in? Andrew, yep.
Yeah, if I can just make a few comments about vapes so that we can be absolutely clear. So certainly, if you smoke, then absolutely converting to vapes is the right thing to do, and we would all, I think, in the healthcare community support that. The vaping is, by a huge margin, the most successful way of coming off cigarettes. So again, that's a bonus. It is true that because they haven't been around for that long, if you have never smoked, then obviously we wouldn't recommend taking up vaping because we don't know what the long-term effects are. But the early data or the early side effects problems, if you like, things like popcorn lung, which you may have heard of, have come from chemicals within vapes that are not available in the UK or in the EU. So these are typically Far East imports available on the net. So the problem that we have with restricting access to vapes for young people is that they are then tend to go onto the internet to get them and so are at risk from that. But UK or EU vapes are as safe as anything.
Thank you, Andrew. I think that's helpful. And look, on these illegal vapes, the bill is going to have to tackle the availability of them outside of what we can do with trading standards. But we know already we need to strengthen trading standards. And as far as young people taking up vaping are concerned, because you're absolutely right about that, it's very obvious, who have never smoked. Some interesting and insightful work was done by the Drug and Alcohol Prevention Committee that we have quarterly. Some really quite detailed research from young people on why they do it. And it was surprising to me that many of the reasons were the kind of old reasons that people used to take up smoking: glamour, peer pressure, being able to. So, yeah, we're really doing a sort of plus ça change health and well-being board this time. Anyway, look, lots going on. Help available, cross-system standing around so that we don't have that happening. And Kelly, thank you for your note. If you need to go, then please do. So with that interesting discussion, everybody happy to accept the recommendations? Okay, thank you. I'm going to move on to last but not least before we get to the WOPE programme. Thank you for waiting very much, patiently. The Better Care Fund, Sue.
Thank you, Chair. The paper presents to the board the BCF plan for 25-26. We have a high expectation that there will be a 2 or 3 year plan from 26 onwards, as we had in 23-25. The guidance has set out the intentions to spend the Better Care Fund, which is a joint fund. The paper will explain where the money comes from and what its intentions are. But we're focusing this year on ensuring safe discharges from the acute and commissioning the services to support the recoveries, the reduction of admissions to the hospital, services for carers and other vulnerable people in our community who need support through our VCS contracts. It also enables us this year, a new element to it, to support the neighbourhood health model, which you've all seemed to have touched on today. And this isn't the solution for everything, but I'm hoping that it's seed funding to have sensible conversations about doing some sort of gap analysis of what's out there, and also focusing on introducing more language on everything that everyone's touched about self-care, so that people know where to get immunisations and the reasons to have vaccination and also screening. So this is an opportunity for us to feed that into the work that the Population Health Management team are doing at Health and Care Partnership and all the other work, and making sure that we have stronger links with the GP. So I'm hoping that that element of it, and I say hope because it's going to be a workforce. It's not me that has all the answers. I'll just make sure that I herd some sheep while we're doing it. But hopefully we'll find some solutions that this money can do for a year.
Thank you very much, Sue. And I think I'd like to record my thanks and the thanks of the board for your work and the work of the team. This is a complicated document. It's riven with mandatory asks from government and requires a lot of negotiation. So we can't just say that's what we're going to do with it. We have to negotiate with partners, and that has been, for want of a better word, spiky at times, but I think you and the team have worked really hard to overcome that. And I do remind the board, before we come to comments, that in the recommendations we are giving delegated authority to Cabinet and to the Director of People to make any changes as required. The future of this fund is not yet known, because it's the government's intention to roll in lots and lots of different grants. 300 have been identified that will be rolled into the overall budget of local authorities. It's not yet known whether the Better Care Fund is going to be one of those, but what is known is that there will, even if it's rolled in, there will have to be an appropriation out to ensure that we maintain a focus on these key things like hospital discharges. So I don't think this area is going to continue to be any easier to navigate than it is now. But a really good piece of work has been done. The detail comes through Cabinet. And as I say, we're also agreeing today, delegated authority, should any changes have to be made, either locally through Section 75 or because we're asked to make those changes before the new settlement comes out. That is a possibility this year that we haven't had before. So with that, any comments, please? After they've waited all that time, no one's got anything. Thank you very much.
Just
thank you.
I wouldn't normally colleagues say to go away thinking they'd wasted the whole afternoon.
Yeah.
To be totally honest, I was lost when I saw this. You know, as a counsellor and an insurance broker, I'm looking at this going, how is this even relevant to what I'm doing, other than the fact it's at this board. So this is just another pot of many pots of money floating around in the healthcare world. I think I understand what it's trying to do, but what are the targets? What are the SLAs? What is a good outcome from the spend of this money? What is a terrible outcome? What is it that we can point to that says this fund is being really well used and it's actually achieving great things for patients? Thank you.
Nice,
Well,
easy question.
Before Sue intervenes, that is laid out in section 9.2 of the report, because it's a £38 million fund. So it's a bit different to some of the other funds. So the things that it reaches into are listed there very comprehensively, and jointly through adult social care and through public health, we contribute to making all of those things happen. But I'll pass on to you to add here, so that you get a chance to let everybody know that you've been here all this time as well.
So the money is managed by senior leaders across the ICB and the Health and Care Partnership and Adult Social Care, so the directors attend. That pot is managed by them, but we have services that serve people going in to stop them going into it. For example, the VCS contracts, we have Health Watch, we do Carers First, we do the Imago service, which is the, someone's talking about social prescribing. They prescribe people, especially those on the island. We also do people coming out of hospital, so we fund the discharge team to get people out of hospital. Okay. And we also commission services for the community equipment. If you need a walking frame to a sling, we supply that from this funding. We also do the intermediate care. So you go home with therapy or you go to a bed with therapy, and lots more besides. We do services, for example, public health do a care program in the hospital, in the care homes to get people strength building. The list goes on. There is a list of most of the things that we cover there, but it touches most residents' lives that have anything to do with health or care.
So, Chair, that's fine. Sorry, I was being a bit flippant. I did pick up some of that. The 38 million I definitely picked up, but when you're spending 120 billion on healthcare, 38 million isn't a lot of money. So, what a nightmare. You've got 3 people managing one pot of money. I can imagine that's quite an interesting conversation on occasion.
Added to that, they're my line managers.
Right. So you're being really polite here, Sue. This is great. But can I just say, the thing I was looking for is, how do we know that this money's being really well spent? What are the metrics and the comparators across different areas that allow us to say that this money's being really well used, or actually, if we tweak this, we could get more out of it? Thank you.
Yeah, thank you. I mean, it's really, really heavily scrutinised. I think that's the first thing to say. And there are a range of key performance indicators that demonstrate, actually, are each of the schemes effective? When I say it's scrutinised by, there's a national team that support the Better Care Fund, but also Sue's mentioned Joint Commissioning Management Group, which is, as she says, all her line managers, but it's a much broader group of people than that, where actually we review the schemes on a regular basis to see if they are really delivering what we need to. And if there are areas that we can flex. So Sue talked about the intermediate care and reablement service. The way that that's been delivered means that if we're seeing a challenge with people coming out of hospital in a certain way and we need to manoeuvre the money slightly, we build the contracts to enable us to do that manoeuvring and to allow us to flex it. At the end of the year, we'll always look at actually what impact has this had. So if we're talking about it from a hospital perspective, the hospital will know that they've got a number of beds. We all know that the challenges that they have with discharge, and actually has the scheme enabled us to move people out of hospital more quickly, home safely. If it hasn't, then we'll look at actually, does that scheme continue next year or do we do something else?
Thank you, Jackie. That's brilliant. I'm just wondering then, where is the public scrutiny of that happening? Because if it's happening within officers, and I hear a lot of officers telling me, oh yeah, this is really well scrutinised. I think it was the one of the funds that's in the Regen portfolio. I got, oh yeah, this is really well scrutinised. It's only 300 grand, but it's really well scrutinised. So where's the public oversight of that sit? Is it a HASC or is it with the cabinet? I was just...
We have HASC. We do go to HASC. We also have each of the commissioned services have a patient voice throughout it. And all of the commissioned services also have any safeguarding issues or any concerns from a patient goes through the community, the patient safety group at the HCP, or also through safeguarding and adult social care. So there's and complaints, any complaints that come through for all of the services that we do, that feeds and leads, the learning goes into the commissioning again.
So are people happy to accept the recommendations, including the delegation, should we need any changes? Okay, thank you. More murmuring. Last thing then, the work programme. Stephanie, I'm going to pass over to you. And if people look at the appendices, please, that tells you what's coming up and where we've got a bit of space, particularly in June, to add other things. And one of the things that I'm keen to add to the programme is for us to have a look at neurological disease and the associated services. I was at the Medway Neurological Network AGM last week. One of the things that is happening is that the prevalence of neurological disease, although it's not currently an NHS priority area, because obviously the number of people who are affected, mercifully, is quite small, there is a rise in neurological disease because we've got an aging population, and people with a neurological disease are more likely to get a pulmonary disease, a disease of the lungs, associated with it. So I think it is a good time, perhaps to have a bit of a focus on that, to think about the way that we serve people with neurological disorders and other rare conditions. And in particular, there was an undertaking, so Malty, perhaps you can feed this back for us, from Sedi Fedrick last year at the Medway Neurological Network AGM to consider how the ICB can work better with the neurological network itself, but more widely with that group of patients. So I think having a look at that, and we've had an offer from Dr. David Oliver, eminent in that field, to come and do a presentation to let us know how neurological disease affects people in the population, how we deal with it, how we care for those people. We do provide actually quite a lot of specialist care in Medway in various different locations. So I would like to add that. And with that, as you can see, we're continuing with our themes so that we keep a good eye on the joint health and wellbeing strategy outcomes. Okay. Scott, yep.
I just wanted to add that we will also be taking Lidsing at June, following discussions with the ONS chairs, vice chairs, chairpersons, and opposition spokes. It was agreed that this forum would be the best place for discussions to take place because we do have all the partners on the board here as well.
Very helpful. And just before you come in, Simon, for the board, particularly for visitors, Lidsing is a huge housing development just over our border that is going to impact on our health services, which is why it's important to discuss it here. Simon, please. Okay.
I'm going to bring Scott in as well so that he can obviously let us know what he's planning to bring under the Reducing Poverty and Inequality theme.
Yeah, so for those who don't know, so the theme 2, well, I'm sure everyone knows, theme 2 for the Joint Health Wellbeing Strategy is reducing poverty and inequality. So we've sort of pre-assigned June to be the theme 2 meeting. Apologies, we didn't have it ready for the pre-agenda meeting, but now having reviewed our performance indicators across various, so each of the themes has a suite of performance indicators, and having had a look through the performance indicators and seen what we're red on, and red obviously means bad, maybe probably performing in a poorly against the national average or not as well as against our peers. So the 4 topics which kind of jumped out as being potentially red indicators and could be opportunity for discussion were proportion of 16 to 17-year-olds who are not in education, employment or training, because obviously that has a big impact on poverty and inequality. Improving outcomes for children in care and care leavers was another area of red, and percentage of the population who are in contact with secondary mental health services that are in paid employment, aged 18 to 69. So it's about people with mental health, being in employment or not. And then the 4th, and then one of the sort of core themes. So each theme 2 has a number of sub-themes, and the 3rd sub-theme is very focused on housing. So again, one area for suggestion that hasn't been brought to the board for a period of time would be looking at how we're preventing homelessness. And there is obviously a fair bit of work on that on the prevention chapter within the prevention plan already. So there are 4 suggestions. So NEAT, housing, children in care, and percentage of population in secondary mental health services, 18 to 69, not in employment.
Well, thank you. I think it's fair to say that we can accept those, and we'll take the, I've just, said to Stephanie, we'll take the neurological network off June and move it later down the year. As long as it comes, they're flexible about that. And if we're having LIDSing actually in June, that fits in quite nicely with some of those themes, doesn't it? Julia, were you? Oh, you're just waving. Okay, yeah, just seeing a bit of a wave. Andrew.
I'm really pleased to see LIDSing come, because obviously it really affects Hempstead and Wigmore in a big way, and Hempstead currently does not have a doctor's surgery, for example, so be interesting to see what officers can say. I just wondered, we're almost at Regulation 19 for the local plan, and at the Regulation 18 stage, there was big gaps in the response from healthcare providers about how we're going to accommodate these 17,000 houses and what the healthcare frame, what that's going to look like. And I wonder if there was an opportunity to come back to this board, because we've got lots of partners in the room to talk about, they've had lots of time to think about it, but can we have some information and have a discussion about what healthcare is going to look like over the next period as we move, because Regulation 19, effectively the local plan becomes, Regulation 19 almost becomes the local plan. I know it has to still go through its inspection process, but there's not much turning back from that, and I'd be very interested to hear what the health sector are going to be doing.
I think, first of all, good idea in principle, and Catherine has been here before from planning for just that purpose, so it's probably quite timely that she comes back. What we need to check, and perhaps I'll ask Simon for you to work with Stephanie, we don't want to inhibit any aspect of Regulation 19 by bringing something here before it's either come through the right place or the consultation. So if you can check that for us, we'll come back to everybody on whether it's possible for us to do that. Is that all right with you, Simon?
That's fine, yeah. I'm obviously between now and when the full council discuss and make a decision on the Regulation 19, there is an opportunity for anyone to come here because the timetable is so tight. There is going to be obviously a round of members' consultation and stuff like that before that date, so members will have a chance to see the sort of draft document as it goes into the full council meeting. But certainly after the June date, we can try and fit something in.
I think it's just worth bearing in mind that the challenge to a Regulation 19 would be something serious like hospital provision, for example, because the local plan fails if you can't provide healthcare, if someone challenges it. And so I'm hoping when the Regulation 19 gets published, we're going to have a really clear plan from Medway or from maybe the ICB about where we're going to provide acute services, for example, across a much expanded population. But I'll take your point. If a later meeting works,